হ্যাঁ, মালিয়া আপু আছেন।
ওকে, মালিয়াপুর সাথে একটু কন্ট্যাক্ট করো, করে আমি রিদওয়ান স্যার ইসলাম আমি লাইভ শুরু করে দিব। হ্যাঁ,
ঠিক আছে, ঠিক আছে। আমরা এখন ইউটিউব লাইভে আছি, স্টার্ট করে
আমার
ফেলুন।
রিদওয়ান স্যারের সাথে করে দাও, কানেক্ট করো। রিদওয়ান স্যার কই?
হ্যাঁ, রিদওয়ান স্যার আপনাকে একটু আনমিউট করতে হবে। এই লাইভ শুরু হয়ে গেছে অলরেডি। রিদওয়ান
ওকে,
স্যার
আনমিউট করছে। হ্যাঁ, শোনা যায়?
জি স্যার, শোনা যাচ্ছে।
ওকে,
স্যার আমি ইন্ট্রোডাকশন করে শুরু করে দিচ্ছি স্যার।
হ্যাঁ ঠিক আছে।
রাহাত শুরু করব?
হ্যাঁ, শুরু করে ফেলেন, লাইভে আছি আমরা, সবকিছু রেডি।
সবাই শুনতেছে তো না?
হ্যাঁ, সবাই শুনতেছে।
হ্যাঁ শুনতেছি
দুই
ভাই,
গ্রুপে তো পোস্ট দেওয়া আছে। ওকে, তাহলে রাহাত আমাকে দেখা যায়?
জি ভাই, দেখা
হ্যাঁ
যাচ্ছে।
দেখা যায়। হ্যাঁ।
এক মিনিট। ওকে রাহাত, শুরু করলাম। Dear physicians, I am Dr. Ehsanuজ্জামান. Welcome you all to today's scientific session on approach to the patient with acute febrile illness. Today's presenter is living legend of medicine, Professor Ridwanur Rahman. He is one of the pioneer medicine and infectious disease specialist of the globe. He has immense contribution in making national guideline of malaria, dengue, and recent COVID-19. So let's not waste the time. Let's go to the business. I am hand over our session to Professor Ridwanur Rahman. Please welcome Professor Ridwanur Rahman.
Okay, thank you very much. Can you hear me? Can you hear
আমি
me?
শুনতেছি
you
স্যার।
people? Okay. Are your people are ready?
Yes sir, you can start. Malia
Okay.
apu, please start the screen share.
Okay. This session was supposed to be presented by Professor Sayyid Atikul Haq. He requested me yesterday to take this session because he has unfortunately been stuck to some other unfortunate event. So I'll try to present a relatively common topic. I have nothing new to say to you. You all know what is acute febrile illness is. Acute febrile illness are considered conditions which causes fever of less than 2 weeks duration. So if the duration is more than 2 weeks, then it becomes so-called fever of undetermined origin, FEO, which was previously called PO or pyrexia of unknown origin. So in discussing the acute febrile illness, I'd like to initiate by saying that acute fever is a rapid onset of fever and symptoms such as headache, chills, and muscles and joint pain. It's quite common in the tropics and subtropics. So Bangladesh is in the subtropics. And frequently such fevers resolve without treatment. But sometimes fever may also herald the onset of severe, potentially fatal illnesses. Can you change this slide, please? An elevated body temperature may have several effects on the body. And these are the immune system chemicals release the production of cells that fight off the invading bacteria or viruses. That means the polymorphs. High temperature also inhibit growth of some bacteria and viruses. And the increased heart rate that accompany the changes in blood circulation also speeds the arrival of white blood cells to the site of infection. So these are all beneficial effects of fever. Next, please. So in considering the fever in terms of diagnosis, we consider in two ways. One is a syndrome, the other is a disease. So syndrome is a group or cluster of symptoms and signs that characteristically occur together in the same patient and which may be due to a number of causes. So a syndrome says that this syndrome could be due to a number of diseases rather than a single disease. Whether when we call a disease, it is a specific pathological abnormality or a set of abnormalities impairing health or function in an organ or system of the body. So disease is not syndrome, syndrome is not disease. So in general, in diagnosis diseases, we try to convert every symptom into a syndrome such that we can make a differential diagnosis. Next. So fever is defined as any body temperature elevation over 100 degrees Fahrenheit. And healthy body temperature fluctuates between 36.1 degrees or 97 degrees Fahrenheit and 100 degrees Fahrenheit, with the average being 98.6 degrees Fahrenheit or 37 degrees Celsius. The body maintains a stability within this range by the help of a thermostat, by balancing the heat production, by the metabolism and the heat loss due to environment. So these two combination keeps the body temperature in a level which remains within the range. The nervous system constantly relays information about body's temperature to the thermostat situated in the hypothalamus, which in turn activates different physical responses designed to cool or warm the body, depending on the circumstances. Determination of fever, there are various ways of determination of fever. One of them is tactile fever. That means হাত দিয়ে দেখলাম ওর জ্বর আছে কি নেই. Is said to be useless. It cannot determine fever. Next. The otic thermometers used in ears are quite sensitive and can be used for determination of fever, but it should not be used under 6 months of age. Auxiliary temperature is unreliable. Elevated temperature is indicative of a fever, but low or normal may not be useful. That means showing a normal auxiliary temperature does not exclude that the patient does not have fever, because there are many fallacies of determination of the auxiliary temperature. At the same time, when we see in the emergency room or in our outpatient that a patient does not have a fever, we still need to call them a fever if an infant, for example, or a child or anybody determined to be febrile at home by a reliable method must be presumed to have been febrile, since even if the temperature later in the emergency department is normal. So it's not only temperature now, it is history of fever within the last 24 hours constitutes a fever. So while we try to approach a patient of fever, we first try to determine that all febrile patients who are toxic appearing should be separated from the rest of the fevers. And toxic appearing febrile patients should be hospitalized for evaluation and treatment of possible sepsis or management. But there is confusion regarding the determination that what is meant by toxic. Toxic is something, is said that you cannot, you can easily identify when you see the patient, but it is very difficult to describe what is meant by toxic. So there are some terms which are used and can be used for determining the toxicity. These are called, one of them is lethargy. That means level of consciousness characterized by poor or absence of eye contact, or as the failure of a child to recognize parents or interact with persons or objects in the environment. This is toxic. Signs of poor perfusion or marked hypoventilation. Poor perfusion means we can detect it by pulse oximeter or by looking at the cyanosis. Hyperventilation, if a febrile patient is hyperventilating, is cyanosed, we need to call them toxic API. And the toxic patient always mandates an aggressive workup, an empiric antibiotic, and hospitalization, admission to hospital. Next, please. So when we approach acute febrile syndrome, is caused by a number of diseases. There is no single disease. There are hundreds of diseases which can cause an acute febrile syndrome. So the illness to be distinguished from each other with sufficient accuracy to guide treatment that will address the cause and to provide information needed to plan and prioritize management options. Next, please. So this may require two different types of tests. One group of tests are called case management tests. That means tests to guide treatment where patients first seek care. And screening tests. That means tests to identify the most common pathogens in a population to guide presumptive therapy and planning. So these two types of management tests we require when we consider that the patient is an acute febrile illness. Next, please. So the causes of severe acute febrile illness are numerous and account for most preventable deaths in low-income countries, particularly in children. So a fever may be nothing that he will recover without any treatment. And again, the fever may be a very sinister consequences, especially in low-income countries, particularly in children, that they may cause death. Next. So if we look into the prevalence of fever in the emergency room, you will see that fever is part of the presenting complaint in 6% of all adult visits to the emergency room between 18 and 65 years. And it is 10 to 15% of all elderly visits to the emergency room, which are more than 65 years. And 20 to 40% of all pediatric visits to the emergency room are due to fever. So it says that fever in the emergency room is not uncommon. It's very common. Patients presenting to the emergency room are due to fever. So pyrexia can be classed as low grade, moderate, high grade, or hyperpyrexia. Again, febricula is a term which is used for mild fever of short duration, of indefinite origin, without any distinctive pathology. Is a very short duration fever. I had many a times these types of fever, and my teacher used to call it that you have a bhallukka jar. বলে যে ভাল্লুকের জ্বর হয় একদিন থাকে, তুমি কেমনে একদিন স্কুলে আসো না, জ্বর ছিল, আমি বুঝি না। So febricula may occur without any symptoms, without any other symptoms, without any known origin, and without any distinctive pathology. Next. So in consideration of the differential diagnosis of fever, we want to look at three different types of acute febrile illness. Some of them are emergency treatable diseases, which are the most important focus of our assessment and management, are the emergency treatable diseases. Some are non-emergency treatable diseases. That means they may be treated on an outpatient basis. Some are non-emergency, non-treatable diseases. That also can be one of the differential diagnoses. So whenever we are looking at a differential diagnosis of fever, we can classify them as into one of the three categories and prioritize them for immediate treatment and hospitalization for emergency treatable diseases. Next, please. So whenever a patient with acute fever presents to us, the first and foremost is to look for signs of severity in the patient. Because this signs of severity says that maybe this patient is suffering from an emergency treatable disease where we should respond very early and emergency. These are called severe tachycardia, tachypnea, respiratory distress, and in any case, oxygen saturation less than 90%. If the patient is in shock, if the patient has an altered mental status, if the patient has petechial or purpuric rash, meningeal signs, seizures, heart murmurs, severe abdominal pain, dehydration, critically ill appearance, bulging fontanelle in the young, and temperature more than 106. So all these conditions will constitute a severe disease, a sign of severity of the disease, and if they are present in any or in combination, we need to treat them as emergency treatable diseases. So again, when we are approaching a patient, we can look at many different components that we correlate fever with age, because many of the age groups have different types of etiology of fever and which can be determined only by seeing at the age. We also use fever pattern, whether this is intermittent, continuous, remittent, though these patterns are not very specifically diagnostic, but still we want to look at the fever pattern. Duration of fever is very important in evaluating the fever, and this duration has to be done by days rather than by weeks, rather than by months, because the duration of fever is very important, I will say later. So fever in returning travelers who has traveled to other countries of or other regions, for example, in Dhaka, if a patient returned from Bandarban, we need to think of something else also, in addition to if he was not traveling somewhere. So some of the pattern syndromes, characteristic syndromes of fever, which we try to differentiate. Next, we look at the fever with underlying diseases. This is a different group of disorders. We'll talk later on. Next. And we say fever with non-specific signs rather than a specific organ-specific signs. They have non-specific signs. And fever with focal signs and symptoms. For example, fever with cough means fever with focal symptoms and signs. Some of the fevers of unknown origin, and also fever with non-specific laboratory finding. We see sometimes only ESR is elevated, only CRP is elevated, only there is leukocytosis, but I do not find any other localizing symptoms or signs in the patient. So fever pattern in general, correlation between fever pattern and a specific disease is weak. Notable exceptions are relapsing fever and sustained fever, which often indicates some specific diseases. So the fever patterns you all know, I will not go into details. The sustained fever, remittent fever, intermittent fever, and hectic fever. So hectic fevers are remittent and with high spikes. So this fever pattern is now interrupted, because most of the sustained and remittent fevers, we can convert them into intermittent fever by use of the antipyretics. So over-the-counter availability and use of the antipyretics may convert most of the sustained and remittent fever into intermittent fever. So while taking history of intermittent fever, we need to take history in such a way that does the fever goes down without antipyretics? So if the fever comes down to baseline without antipyretics, that is an intermittent fever. If it comes down with antipyretics, it is not an intermittent fever. So you need to ask about the defervescence. That means disappearance of the fever, whether or not with treatment or without treatment. If the fever disappears to baseline without treatment, without antipyretic, it will be called intermittent fever. Next. So there are some fevers which can really comes to us with high-grade fever. So I will not mention all of them. You can see them on the screen. So most of the flu-like illnesses, influenza-like illnesses, or the other viral illnesses develops fever, high-grade fevers. So we ask them, do you have fever coming to very high in first 24 hours? For example, fever comes with chill and comes to 104 in first 24 hours. This indicates a viral illness. Despite that, many other illnesses written here can also cause very high spike fever. So meningitis, encephalitis, sepsis, malaria, infective endocarditis, all these can cause high-grade fever. But unusually, they can also cause low-grade fever. But most of them will present to us with one of these diagnoses with a high-grade fever. Next. Relapsing fever, that means fever stays for some duration, then they are febrile for some duration. Again, there is a period of fever so for example, in Prevalence fever, the patients have fever continuous for 7 to 10 days. Then there is an febrile period of 7 to 10 days. Again, have a febrile period of 7 to 10 days. So these are the fevers which can cause very characteristic intermittent fevers. And patient can say characteristically that I don't have fever sometimes. Then again, it comes to fever. So these are some of the conditions: relapsing fever, malaria, rat bite fever, familial Mediterranean fever, Charcot's intermittent fever, and Prevalence fever of Hodgkin's disease, brucellosis, etc. Next, please. So some of the diseases characteristically causes sustained fever. Many other diseases also can cause sustained fever. But these diseases are characteristic of sustained fever. So they do not go to baseline without antibiotics. These are called lobar pneumonia, rickettsial diseases. Especially the drug fever is often a sustained fever. Typhoid fever, typhus, and CNS damage due to encephalitis and other conditions. Next, please. There are some fevers which are characteristically intermittent. So intermittent fever classically is suggestive of malaria, calazar, and pyemia. That means abscess. Some of the condition causes double quotidian fevers. That means there are 2 peaks in 24 hours, are called double quotidian fevers. So these are often found in Still's disease, legionellosis, miliary tuberculosis, calazar. And so that's why we need a temperature chart. Body temperature is the vital sign. It has been used for long. So even if the patient does not have fever, you use a temperature chart when you are treating a patient in hospital. This is very routine for very long. So temperature chart is the only way how can we determine the type of the fever. So quotidian fevers like Plasmodium falciparum, Plasmodium knowlesi, malaria, where patient can say that sir, aজকে আমার জ্বর আছে, কালকে থাকবে না, পরশুদিন আবার এই টাইমে জ্বর আসবে. So this is quotidian fever, often found in falciparum and knowlesi, malaria. Tertian fever means alternate day fever or every 3rd day fever. And quartan fever is every 4th day, every 3 days will be gap. So these types of fever suggestive of Plasmodium malariae can cause these types of fever. Next, please. Next. So hyperpyrexia, that means fever going more than 106 or 107 if it is rectal temperature, is suggestive of intracranial hemorrhage, sepsis, Kawasaki's disease, thyroid storm, drug fever, and heat injury. That means heat hyperpyrexia. So all this, when you have a patient of hyperpyrexia, consider one of these differential diagnoses. Hectic or a spiking fever, often suggestive of biliary or urinary fever, and maybe endocarditis. That means the fever goes to 104.5 sometimes, and at other times there is no fever or a low-grade fever. Saddleback pattern, that means fever goes away once, again fever comes. Saddleback শব্দটা এসছে উটের পিঠের মতো, উটের দুইটা ঝুড়ি থাকে, তাহলে ফিভার প্রথমটাতে চলে যায়, আবার গিয়ে সেকেন্ড পিকটা হয়. So this is often found in dengue fever, leptospirosis, poliomyelitis, and human granulocytic ehrlichiosis is a tropical fever. So some patients, we know that tuberculosis has a characteristic evening rise of temperature, but some of the patients may have morning rise of temperature. So morning rise of temperature can also be there in tuberculosis, in typhoid fever, and characteristically in polyarteritis nodosa disease. Next. Fever and shaking chills. Some of the fever are associated with shaking chills. প্রথমে বলে যে আমাকে একটা কাঁথা দাও, কাঁথা দিল, বলে যে আমাকে একটু চেপে ধরো, জোরে চেপে ধরো, দুজনে চেপে ধরে, চারজনে চেপে ধরে, এমন শেকিং চিল হয়, পেট টেট সহ কাঁপতে থাকে। এরকম শেকিং চিলস যদি হয়ে থাকে, we consider one of these differential diagnoses, like pneumonia, sepsis, malaria, visceral abscesses. That means abscesses anywhere inside the body. Legionnaire's disease, pyelonephritis, bacterial endocarditis, filariasis, all these can cause fever with shaking chills. And you know that the coronavirus can cause chills without fever. So it is said that more frequently patients have chills rather than fever unless they are admitted to hospital. So at hospitalization, only 48% of the patients with coronavirus disease has fever. Fever comes later in the hospital. So chills are more pointing to corona disease rather than the fever. Next, please. Fever patterns, again, fever with age, if you look at. So fever in a newborn between 0 and 7 days is always pathological and is often due to early onset sepsis or torch infections. If it is between 8 to 30 days, newborn, late onset sepsis, and nursery infections are the cause. And in both this disease, so up to 30 days, the most important cause of fever is sepsis, which is potentially life-threatening. For this reason, any fever less than 30 days will have to be hospitalized. This is a very unlikely, you need not look for toxicity. If the age is less than 30 days, any fever will require hospitalization because up to half of them has sepsis. Between 8 to 30 days, okay, between 1 and 2 months, young infant are late onset sepsis. So it is indicated that any fever less than 3 months, you may hospitalize all these patients because half of them have sepsis. If the fever is between 3 to 24 months, that means up to 2 years, infant, the fever is often due to primary bacteremia, meningitis, UTI, or viral infections. So you need not hospitalize them. You can investigate them to confirm a diagnosis, or you can empirically treat them for bacteremia. So if it is preschool years, 2 to 5 years, the most of the causes of fever are meningitis, pneumococcal infection, systemic hemophilus infection, and viral infections. So we need to consider this differential diagnosis when fever is between 2 and 5 years. If it is between 6 to 12 years, that means primary school children developing fever, you need to consider mycoplasma, streptococcal pharyngitis, viral hepatitis, UTI, and other viral infections as the cause. If it is between 13 and 20 years or 18 years, a teenage, consider infectious mononucleosis, mycoplasma, viral infections, UTI, and sometimes sexually transmitted diseases. So if it is more than 65 years, often consider UTI, anemia, pneumonia, viral infection, and sepsis as the cause. That's why more than 65 years patient, if the empiric antibiotic does not respond in 48 hours, you need to hospitalize them for parenteral antibiotics and further investigation. Next, please. duration of fever is very important. I say that you need to ask the patient of the duration by days, because 7 days is such a cutoff point that if the patient has fever of less than 7 days, in tropical and subtropical countries, 80% of the fevers are due to viral illness and self-limiting viral illness and needs no investigation. But if the fever causes 4 or 5 days or 7 days, has high fever, you need to consider them investigation or empiric treatment. Next, please. So fever lasting for more than 2 weeks indicates serious underlying problem and needs thorough investigation. These are not acute fevers. Next. So in approaching the fever, we approach is called a diagnosis by prevalence. That means where you are a physician, you need to know which fever is now running in the community. For example, in Dhaka city, now we have a patient of fever and cough. You will say them as corona infection because corona is prevalent now. If you work in Agra city and if you find an intermittent fever coming with chill and rigor, you will consider them as malaria unless proved otherwise. But if it is non-corona in Dhaka city, you will never consider this fever as malaria because malaria is not there in Dhaka city. And these types of decision making on the prevalence of diseases in the community is called diagnosis by prevalence. So we diagnose by prevalence in tropical, subtropical countries that any fever of less than 7 days duration is a viral fever unless proved otherwise. So count the duration of fever by day. The next thing, it is said that fever comes from involvement of one of the organ system in the body. So we need to try find the organ of origin of fever. So try to identify organ of origin of fever is associated symptoms are the key. So whenever a patient comes to you with fever, you need to ask what else? What else you have? For example, if a patient says that I have cough, we say that this fever is originating from the respiratory tract. If a patient has fever, dysuria, frequency, urgency, we say that fever is originating from the urinary tract. If a patient with fever have diarrhea with visible blood in his stool, for example, the fever is arising from the GI tract. So in this way, we try to allocate or assess a fever by its organ of origin, because we know that every organ has some diseases which can cause fever. A thorough systematic inquiry is essential in evaluating fever. So systemic inquiry is nowhere is more important than in eliciting fever patients. So you need to ask questions from every system in the body such that you can localize the fever, where from it is originating. Temporal profile of the fever should be identified because many of the fever has a characteristic temporal profile. For example, in patients with viral fever, fever comes to very high in first 24 hours. Whereas in a patient with enteric fever, fever goes on in a step-ladder pattern. So in many patients, in children, mother will say that my baby is suffering for 3 months from fever. But in most of the cases, they are suffering from 2 or 3 episodes of fever in 3 months, rather than the baby has a fever for 3 months. So temporal profile of the fever should be identified. In taking history of the fever patients, you need to ask the dose, duration, dates of beginning and ending of the antibiotics, route and compliance of previous antibiotic is essential. For example, you are taking history of fever, history of treatment from a patient with enteric fever. The patient says, I have taken ciprofloxacin, azithromycin, ceftriaxone, everything. Still I have fever. Then you need to ask, ceftriaxone, how much dose you took? He says 1 gram daily. So 1 gram daily is not a is not a dose for enteric fever in adults. So we should not label him as drug resistant because he took inadequate doses. Or if you ask, how many days, what is the dose you are taking of ceftriaxone? He says 2 gram BID. You need to ask, how many days did you take it? He says it is for 3 days. So this duration is not enough for treating enteric fever. That's why we need to ask about the dose, duration, dates, and route and compliance of the previous antibiotics to treat the patient now. A thorough record of comorbidities is essential in evaluating a history of fever if the patient is diabetic, if the patient is mainline drug abuser, if the patient is neutropenic, if the patient has other conditions. We need to consider those differential diagnoses which are associated with comorbidities. Next, please. You need to tell me when I exceed the time. Then I will go fast forward. So diagnostic clues. Sometimes we look for clues. So fever with anemia. You have no other features in the patient. Fever with jaundice. Fever with an obvious rash. Fever with lymphadenopathy. Fever with white cell abnormalities like eosinophilia, neutrophilia, neutropenia, etc. So all these clues we need to acquire and accommodate while trying to diagnose a patient of fever. Next. So fever with anemia, you know. Kato? 5 minutes?
15 minute.
Okay.
Or 15 minute.
Okay, thank you. So these are the conditions where we can have fever with anemia characteristically, but we need to know that in Bangladesh, many women, many people are anemic from pre-existing conditions. So fever with anemia does not necessarily mean all these diseases. Maybe the patient had pre-existing anemia and now has a fever. So we need to consider both ways. Next. Fever with jaundice is dangerous. Fever with jaundice is an indication for hospitalization. So viral hepatitis is one of the cause of fever with jaundice. But we know that most of the viral hepatitis, fever is a feature of the prodrome. Fever does not extend into the clinical icterus, with the exception of hepatitis E virus disease, where the fever can take a course like that of enteric fever. So if a patient has fever and is still jaundice, you consider it a hepatitis. This is a hepatitis E virus disease. In other viral hepatitis, fever is a feature of the prodrome. So Epstein-Barr virus, malaria, typhoid, leptospirosis, cytomegalovirus, all these diseases can cause fever with jaundice. Next, please. Fever with an obvious rash. Meningococcemia is a medical emergency. The other conditions are often not emergency. So all these conditions like rickettsial spotted fever, viral hemorrhagic fevers, dengue and arboviral infection, leptospira, secondary syphilis, sometimes collagen vascular disease and drug reaction are fever with obvious rash. Next. Fever with lymphadenopathy. If there is only cervical lymphadenopathy, we consider atypical tuberculosis, primary toxoplasmosis as the cause and cataspase disease. Fever with generalized lymphadenopathy is often infectious mononucleosis. It could be trypanosomiasis, toxoplasmosis, leptospirosis also. Next. Fever with white blood cell abnormalities. Some of the patients with fever have eosinophilia. Often they are due to parasitic infections. So parasitic infection causing fever often has fever with eosinophilia. Neutrophilia is often due to pyogenic abscess, leptospirosis, relapsing fever. Even hepatic amoebiasis and collagen vascular disease can cause neutrophilia. Neutropenia is a very specific localizing condition that viral infections and rickettsial infections, including typhoid, may cause neutropenia. So neutropenia is a condition where we do not use empiric antibiotics except for specific conditions when you try. Next. Collagen vascular diseases can cause fever, but you see characteristically I don't include rheumatoid arthritis. So it is said that fever is not a feature of rheumatoid arthritis. If a patient with rheumatoid arthritis has fever, consider something else than rheumatoid arthritis. So the common collagen vascular diseases causing fever are juvenile rheumatoid arthritis, Kawasaki's disease, and rheumatic fever, which is rare nowadays. Next. So other fevers are drug infections, drug reactions can cause very high fever to very low fever and can continue for very long. Some of the tumors can cause fever. So these are mostly lymphomas, hematological malignancies, renal cell carcinoma, and some other cancer, neuroendocrine tumors can cause fevers. And some of the familial fevers, that means they have a habitual fever, the patient have a higher body temperature for habitual, is not disease. Next, please. So bedside clues are most important. So in the bedside clues, we try to differentiate 3 groups of fever. One is fever with localizing signs. That means there are organ-specific symptoms or signs. Fever without localizing signs. That means patient has fever, but no organ-specific symptoms and signs. And some of the patients with fever with non-specific signs, very difficult to diagnose these fevers. Next. So fever with localizing signs are so many. So for example, viral upper respiratory illness, one of them is COVID-19. So cough and rhinorrhea, no systemic symptoms, is an upper sinusitis. Next, go quickly. Pneumonia, retropharyngeal abscess, etc., etc. Hepatitis, rash indicates. So other fever with localizing signs are meningitis, otitis, mastocytitis, osteomyelitis. You have a specific physical signs to treat these diseases, to diagnose the diseases. So it is relatively easy if the patient has a localizing sign. We face problem when patient do not have a localizing sign. Next. So these are the fevers with without localizing signs. For example, malaria is characteristically has no localizing symptoms and signs. Splenomegaly is a feature in the child. It's not in adults. So adults develop splenomegaly after 7 days in malaria. Whereas in children, you can have the splenomegaly early in the course of the illness by 2-3 days. Sepsis, no localizing sign. Malignancy, typhoid, UTI, infection associated with HIV, other protozoa, Bartonella, arboviral fevers, hemorrhagic fevers, all these have no organ-specific symptoms and signs. Next. Fever with non-specific signs, we say these are the fevers with non-specific. That means you have fever, only splenomegaly, no characteristic organ-specific symptoms or signs. And we cannot characterize. Fever with anemia, nothing else. Fever with an abdominal mass, fever with hepatomegaly. So these are considered fever with non-specific signs. You might get one of these fevers sometimes. Next. So some of the fever occurs with underlying diseases. We need to segregate them as severe disease because these fevers with underlying diseases are potentially severe illnesses. For example, fever in the neutropenic cancer patient, fever in diabetic patients, fever in alcoholic patients, fever in intravenous drug users, fever in HIV infected patients, fever in patients with splenectomy. So the conditions or the reasons are different. Next. So if you look at fever in alcoholic patients, there are many such causes of fever. One, alcohol withdrawal, delirium tremens, hepatitis, pancreatitis, subarachnoid hemorrhage, pneumonia, TB, spontaneous bacterial peritonitis if the patient has cirrhosis. All these conditions we need to consider if a patient is alcoholic. Next. If a patient life-threatening associated with diabetes, some of the these are mucormycosis, rhinocerebral, malignant otitis externa, emphysematous cholecystitis, emphysematous pyelonephritis, necrotizing fasciitis, sepsis, all these are associated with diabetes mellitus. You need to consider one or the other of them if the patient is very sick and toxic. Next. Fever with intravenous drug abusers, you know that these are the conditions which can affect intravenous drug abusers. and we consider one of the differential diagnoses when the patient is a mainline drug addict. Next. So in evaluation, most important laboratory evaluation for a case of fever is the white blood cell count. So it has been recommended as a screening tool since the 1970s. And WBC remains a useful screening tool because it is rapid to perform and it is widely available. Total WBC count, absolute neutrophil count, absolute band form of the neutrophils have all been shown to be associated with serious bacterial infection. Next. So values for WBC. If the WBC count is more than 15,000, are associated with SBI, serious bacterial infection. So sensitivity of serious bacterial infection, if the count is more than 15,000, the sensitivity is around 50%. The specificity is very high, 76 to 80%. Next. I'm not talking of the others. So absolute neutrophil is more important than the total neutrophil count. So if the total neutrophil count is 7,000, neutrophil count is 99,000, it does not mean infection. So infection causes neutrophilic leukocytosis, not a relative neutrophilia. So if the patient's total count is normal, only neutrophil is elevated, it is called relative neutrophilia. Relative neutrophilia does not necessarily mean infection. So infection means there will be neutrophilic leukocytosis. In some condition, relative neutrophilia may be a bacterial infection. If there is an absolute band count or absolute neutrophil count are associated with serious bacterial infection. Next. Elevated absolute neutrophil count is slightly better than WBC. Next. So WHO as a marker clearly associated with increased risk of bacteremia at values less than 5,000 and more than 15,000. Less than 5,000 because sepsis can cause neutropenia as well. So if the patient you suspect a serious bacterial infection, neutropenia is suggestive of sepsis in addition to leukocytosis of more than 15,000. However, known to have a poor sensitivity and a specificity, thus inaccurate. So when a patient have a leukocytosis, it is not necessarily infection. So we say that don't treat neutrophils, treat the patient. One of the areas of misuse of antibiotic is considering leukocytosis synonymous with infection. So because of its low predictive value and low prevalence of bacteremia results in unnecessary treatment in more than 80% of the patients. Next. Other potential markers in neutrophils, we look at the band form of the neutrophil count, absolute neutrophil count, band to neutrophil ratio, TSR, C-reactive protein, and procalcitonin. Procalcitonin has been considered as a point of care test of bacterial infection. So if you can avail procalcitonin at the emergency room or in the hospital, it is more suggestive of infection than any other potential markers. So procalcitonin is not only used as a marker of bacterial infection, is also used as a marker for withdrawing antibiotics when the patient is in ICU or when we cannot determine when should we take out the antibiotics. So procalcitonin is a marker of infection as well as normalization of procalcitonin is a marker of withdrawal of antibiotics. Next, please. CRP is an acute phase reactant. We cannot do procalcitonin everywhere. That's why we use CRP as an acute phase reactant as a sensitive indicator of infection, much more than leukocytosis, much more than elevated ESI. Shown to have a better predictive value than WBC or absolute neutrophil count. This is a slide which is not very showing. Is showing how much. Please show there. Is showing how much sensitivity and predictivity of neutrophil count. So if the absolute neutrophil count is more than 1,000, the sensitivity of bacterial infection is around 71,000. If the WBC is more than 15,000, the sensitivity is only 74%. If CRP is more than 70%, more than 7, the sensitivity of having bacterial infection is 79%. It shows that CRP is the most sensitive indicator compared to WBC and absolute neutrophil count. Next. So leukocytosis, neutrophilia, and neutropenia, neutrophilia, and bandemia also indicates if all three together is present, such as severe sepsis, severe pneumonia, and other severe bacterial infections. Next, please. But if the fever with non-specific laboratory finding has a WBC count of more than 50,000, consider leukemia or myeloproliferative disease rather than a bacterial infection. Next. Fever with lymphocytosis. You know, most of the viral infections causes lymphocytosis, absolute lymphocyte count more than 4,000 per microliter. And these are the conditions where you can have that. Next. Fever with monocytosis. Some of the infections causes monocytosis. The characteristic one is infectious mononucleosis. There is absolute monocyte count is more than 950 milliliter per cubic millimeter. And infective and all these conditions can cause IBD, means inflammatory bowel disease, and can cause monocytosis with fever and can indicate one or other of these diseases. Next, please. Bandemia with normal WBC, severe typhoid fever, malaria, severe viral infection, hemorrhagic fever virus. So patients with coronavirus with requiring having the cytokine storm often has bandemia, normal WBC. Next. Fever with leukopenia. Some of the fevers can cause leukopenia, mostly viral infections. However, severe sepsis can cause leukopenia, and malaria, TB, brucellosis, typhoid fever, all can have low normal leukocyte or leukopenia. Next. ESR determination is a commonly performed laboratory test with a time-honored role. However, the usefulness of this test has decreased as new methods of evaluating diseases have been developed, such as CRP and Prof. The test remains helpful in a specific diagnosis of a few conditions, including temporal arteritis and polymyalgia rheumatica, and possibly rheumatoid arthritis and multiple myeloma. All these conditions causes triple digit ESR. That means ESR more than 100. So ESR is very specific to diagnose a patient of headache and fever as temporal arteritis. Next. Next, please. So fever with ESR more than 100. It is not only those 4 conditions, all these conditions can cause fever more than ESR more than 100. So ESR is not predictive of any particular condition. Procalcitonin and CRP are better markers of infection than ESR. Next, bacterial infection than ESR. So now we go towards the end. So assessment, there are a stepwise assessment of fever. So in the first step, when you approach a patient of acute fever, whether you are in the emergency room or in the outpatient or in the admitted hospitalized patients. No, the previous one, step 1. So assess the severity of symptoms and recognize sepsis, because this is potentially life-threatening. So fever, tachycardia, tachypnea, and hypotension provide key clues to SIRS. And if there is organ dysfunction, it is sepsis. You know that their sepsis has a new definition. So after excluding the severe symptoms, we go into step 2. We take a history and clinical examination to assess for fever with localizing symptoms and signs, fever without localizing symptoms and signs, fever with non-specific signs. So in the second step, we characterize the patient into one of the 3 categories. Next. So in step 3, we try use rapid diagnostic tests. For example, malaria, dengue, we can do rapid diagnostic tests, which is available in an hour. Can be made available. In Bangladesh, it's just not often available, but in all of the world, it is available. So we do the rapid diagnostic test to exclude these conditions. Then we go to step 4, where we use antipyretics alone if the fever is less than 3 days in duration and initial RDTs are negative. Next. So in a step 5, if the investigation and management, if fever persists for longer duration, more than 3 to 5 days, and initial RDTs are negative. Next. So in a step 6, we go to acute undifferentiated fever if we find with negative culture that persists despite initial empiric antibiotics, thorough investigations are indicated. So this is the assessment steps for acute febrile illness. Next. So if you can see, I'm not sure, it is again showing the same steps. Fever, first thing you need to assess whether your patient has sepsis. If yes, follow sepsis protocol. If no, look for the localizing symptoms and signs. If you find that the patient has fever, has dysuria, you can treat them for urinary infection. So yes means treat for appropriate. If there is no localizing sign, look for the day of the disease. If day 1 or 2, defer investigations and antimicrobials. Do not use antibiotics. Fever is not synonymous with bacterial infection. Don't treat all patients with fever with antibiotics. If day 3 to 4, consider complete blood count, differential count, malaria parasite, and maybe quantitative Buffy code and urine analysis within this. However, if the patient has day 5 or greater, so we do blood culture before giving antibiotics, and we can also use antimicrobials based on investigation or based on clinical judgment. Next, please. So when to test and whom to test? So first 3 days, usually investigations are not required unless it is definitely indicated. Uncomplicated, not sick, short febrile illness, influenza-like illness, no need for investigation. If the patient looks sick or has unusual symptoms at any time, do appropriate investigation. If area has reports of any specific endemic illness like lepto, malaria, dengue, staph typhus, etc., specifically screen for such diseases among patients coming from such areas. Next. So always communicate to the patient relatives why you decide to investigate or not investigate at that point of time. Next. So indication for hospitalization, you all know this. Still, all emergency patients in need of airway stabilization, ventilation, or continued oxygen requirement. So it is said that one of the most important assessment tool in the emergency room, whether a patient with acute febrile illness requires hospitalization, is a pulse oximeter. So if you see that the pulse oximeter shows less than 93% oxygen saturation, admit the patient. Age less than 28 days, all patients will be hospitalized. Prolonged seizure, status epilepticus, altered sensorium, electrolyte imbalance, signs of severe dehydration, not feeding well, respiratory distress, drugs toxicity or drug reaction, unknown or undetermined concern for non-compliance or inability to follow. All these conditions will require hospitalization. Next. Polymicrobial infection in neutropenic patient, approximately 80% have gram negative, 30 to 30% has gram positive, and gram negative species. Pseudomonas aeruginosa, most common gram negative species isolated in polymicrobial infection. Next. So, okay, these are the infections associated with hematologic malignancies and solid tumor. Most of the infections are gram positive. However, 27% are gram negative, and 1/3 of them are polymicrobial. So when you are empirically choosing antibiotic in patients with solid tumor hematologic malignancies, use treatment for polymicrobial infections. Next. Next. So common sites of patients in infection with cancer or in elderly patients. These are mostly pneumonia, bloodstream infection, urinary tract infection. These three constitute 90% of the causes of common sites of infection in patients with cancer. Next. So general management principles focus on life-threatening and organ-threatening conditions. So these are the conditions when you consider that this is life-threatening or organ-threatening. This indicate emergency treatment. For example, in sepsis, it is said that you strike early. That means within an hour of attending to the hospital, and you strike hard. That means you use broad spectrum antibiotics. So we strike early, we strike hard if the patient has a life-threatening or organ-threatening conditions. Be empathic to the patient, place in a position of comfort, and treat for dehydration. Next. General management principles are use standard precautions, dispose of sharps properly, more important now with coronavirus, follow your hospital exposure control plan, properly discard any disposable supply. Next. Control of fever is tepid sponging is very useful. Tepid sponging means it is not tap water. It is a lukewarm water. If you go very, very cold water, patient will have discomfort, chill feeling, and uncomfortable feeling. So always tepid sponging will be combined with fanning. You need to evaporate the water from the surface of the body to get effervescence. So tepid sponging with fanning. Paracetamol is recommended antipyretic. If the temperature is more than 101, you use antipyretics. Do not give regular dose of antibiotic like TDS 4 times daily, BD, etc. because it will undermine the type of fever. So when patient has fever or pain, only then use paracetamol. The paracetamol dosage of paracetamol in any patient over 50 kg is 2 tablets of paracetamol. 1 tablet paracetamol is a homeopathic dose. So recommended adult dose is 500 to 100,000 every 8 hours, maximum 4,000 milligram per day. If it is less than 8 tablets in 24 hours, the toxicity is like placebo. So you can very easily use 1 gram and 2 tablet 4 times daily in any adult patients. So in children, you need to match the per kg. It is recommended that the formulation, quality, quantity, and frequency of dosing are clearly mentioned in the prescription as well as explained to the patient. Next. Routine co-prescription of antiemetics and H2 blocker is not recommended along with paracetamol. আমার দেশে এমন হয়ে গেছে একটু আগেটাতে রাখ আমার দেশে এমন হয়ে গেছে যে রোগীরা কথা বললেই একটা ওষুধ পাচ্ছে যেখানে কোনো ওষুধের দরকার নেই যেমন একটা ভাইরাল ফিভার আমরা বলি যে ওষুধ খেলে 7 দিন না খেলে 1 সপ্তাহ ওই রোগীটা যখনই বলতেছে আমার জ্বর প্যারাসিটামল একটা অ্যান্টিবায়োটিক সহ যখনই বলতেছে কাশি সর্দি একটা অ্যান্টিহিস্টামিন যদি বলতেছে কাশি বেশি একটা ব্রঙ্কোডাইলেটর যদি বলতেছে আমার বমি একটা বমির ওষুধ মানে ও কথা একটা বললেই একটা ওষুধ দিয়ে দিচ্ছে এইভাবে কিন্তু we do not use drugs. We use drugs mostly on demand. So do not H2 blocker এবং PPI এখন জাতীয় চিকিৎসা হয়ে গেছে. Do not misuse these drugs. These are not harmless. Every drug is a poison unless used in recommended conditions. Next, please. So supportive care with non-pharmacological oral fluids are the safest. Most of the febrile patients are dehydrated at presentation because of the inability to take orally, often have vomiting, and have insensible and sensible perspiration. All these conditions causes a febrile patient to be dehydrated. So all patients with fever has to be asked to take extra fluid than who was taking normally. Home available fluid with some added salt and lime juice may be more palatable. Situations except severe dehydration, a small frequent quantities may be given repeatedly. The fluid type and rate of intake often reduces the need for antiemetics. Next, please. Next. Next. So again, sponging, increased body surface, food. No restriction of food. আমার ছোটবেলায় একবার জ্বর হয়েছিল, আমার এখনো মনে আছে। শুধু সাগুদানা খাওয়াইতো, এমন বৃষ্টি, সেটা একটা নর্মাল লোককে খাওয়াইলেও খাইতে পারবে। ওকে বলতেছে তুমি এবার সাগুদানা খাও, আনফেয়ার, এবং এটা একদম পানিশিং দ্য পেশেন্ট। সো নো রেস্ট্রিকশন অফ ফুড, ওর যেটা ভালো লাগে সেটা খাবে। আমি রোগীদেরকে বলি যে আপনি বিরিয়ানি খাবেন, ভাত না, কারণ হচ্ছে বিরিয়ানি খেলে সে একটু খাইতে পারবে, ভাত হলে সে খাইতে পারতেছে। ওকে বলি যে তুমি আইসক্রিম খাও, মিষ্টি খাও, যেগুলোতে ক্যালোরি চলে আসে। তাহলে হাই ক্যালোরি ফুড, cake, pastry, etc. should be advised during fever, because patient do not have appetite, patient often have vomiting, so we ask them to take anything he likes in a small frequent dose volumes. So the only advice is a smaller quantity at a time and distributed more frequent. Next. So things next. Rest is one of the important things to be done in fever management. Use of covering dresses not to be done. অনেক জামা কাপড় পরাই দিলাম, ব্ল্যাঙ্কেট পরাই দিলাম, ক্যাপস এটসেট্রা, those can contribute to rapid rise of body temperature and febrile fits. Food and fluid restriction is contraindicated. Going to work, school, or any exertion should not be there in patients with fever. Next. This slide I show for a reason, is that you see the last column on your right hand side. It shows the defervescence period, means how long it is required to get defervescence. That means একটা enteric fever এর রোগীকে আজকে আপনি ওষুধ দিলেন, কালকে ভালো হয়ে গেল, সে enteric fever নয়। enteric fever এ জ্বর কমতে কমপক্ষে 3 থেকে 5 দিন লাগে। এইজন্য একটা enteric fever এর ওষুধ পাচ্ছে এরকম রোগী আপনার কাছে তৃতীয় দিনে চতুর্থ দিনে আসছে, don't change the antibiotic, because আপনি ওটা চেঞ্জ করে ওটা যদি থাকে হয়তো কাল পরশু জ্বর কমে যাবে। আপনি যদি একটা নতুন চেঞ্জ করে দেন আবার 5 দিন শুরু হবে। এই জন্য এন্টেরিক ফিভারে বলবেন যে ওই ডাক্তার সব ঠিক চিকিৎসা দিয়েছে, আপনি এটাই কন্টিনিউ করেন, 5 দিন পরে যদি জ্বর 100 বেশি থাকে আমাকে আবার দেখেন, এই কথা বলতে হবে। এই জন্য এটা দেখিয়েছি। তাহলে অ্যান্টিবায়োটিকে একদিনে আজকে সেফট্রাক্সন দিলাম বলেছে সাথে সাথে আমার জ্বর নাই, এটা এন্টেরিক ফিভার নয়। এন্টেরিক ফিভারে সেফট্রাক্সন দিলেও আপনাকে কমপক্ষে 2 দিন 3 দিন 4 দিন 5 দিন সময় লেগে যাবে টু গেট ডিফারেন্সেস। এই জিনিসটা দেখানোর জন্য স্লাইডটি দিয়েছি। নেক্সট। So in conclusion, to all of you, high proportion of short duration fevers are self-limiting, up to 80%. 10 জন 8 জন. Don't treat them with antibiotics. Oldest clinical rules are still applicable in diagnosis and empiric management. Meticulous attempt should be made to identify danger sites and indication for hospitalization. Injudicious lab choices may be wasting of resources and misleading. Next. এই জায়গায় রাখেন, এই জায়গাটা দেখেন, আমরা বলছি যে clinicians have a role play preventing antimicrobial resistance. So WHO and other international agencies have conferred a responsibility on the clinicians to preserve the efficacy of existing effective drugs by not misusing them. So fever is not synonymous with bacterial infection. Leukocytosis is not synonymous with bacterial infection. Pus cell in urine is not synonymous with infection. So I often say to my students, don't treat the report, please. Treat the patient. So you spare the patients with antibiotics such that we can preserve the efficacy of the existing effective antibiotics. Next. Next. So thank you very much. Thank you all for patient hearing. I am ready to listen to your questions and to try answer your questions if I can. Thank you very much. বেশি সময় নিয়ে নিয়েছি না? আমি তো কিছু শুনতেছি না। Hello.
Sir, can you hear me?
Yes, I can hear you now.
Sir,
Yes.
sir, question তো অনেক আছে, স্যার বেশি কোশ্চেন বলবো না স্যার। ডক্টর হাসিবুর রহমানের কোশ্চেন আছে, ফার্মাসিউটিক্যাল কোম্পানিগুলো 1 গ্রাম প্যারাসিটামল ট্যাবলেট বানায় না।
হ্যাঁ, 1 gram is risky because you need to use it for less than 50 kg as well as for more than 50 kg. So you can use 2 tablets easily and you can keep it for less than 50 kg also. So that is the reason that British Pharmacopoeia has recommended use of tablet paracetamol in 500 milligram doses.
স্যার ডক্টর গোলাম মোস্তফার একটা কোশ্চেন আছে স্যার, মানে ফিভার মেজার করার পারফেক্ট মেথডস আপনি কোনটা করেন স্যার, সাজেস্ট করবেন ফিভার মেথডের জন্য, বা মানে মেথড মানে ফিভার
আমাদের
মেজার
দেশের
করতে
জন্য
কিভাবে স্যার আপনার জন্য বেটার
আমাদের দেশের জন্য oral temperature is best. So in measuring oral temperature, you need to put the thermometer into the mouth and keep it for more than 1 minute. It is said up to 2 minutes. And এই 2 minutes এর মধ্যে সে কোনো কথা বলবে না, মুখ দিয়ে বাতাস ছাড়বে না, মুখটা বন্ধ রাখবে। তাহলে এই method of measurement is the best way to measure antibiotic. You can also use otic thermometers, and you can use other thermometers also. Infrared nowadays being used is also very much sensitive.
স্যার আরেকটা কোশ্চেন, ইজ ANC is an available investigation?
Absolute neutrophil count, no, is definitely. You just divide the total neutrophil count by the absolute neutrophil count percentage, then you can detect the absolute neutrophil count. যেমন 10,000 হচ্ছে total leukocyte count, 80% হচ্ছে neutrophil, তার মানে absolute neutrophil count is 8,000. Very easy to detect.
Yes, sir.
So you need to just calculate to determine the absolute neutrophil.
ডক্টর হাফিজের একটা কোশ্চেন স্যার, স্যার ফিভার মোর দেন 4 to 7 days or more than 7 days, which one we prefer for evaluation?
4 to 7 days is better for evaluations. More than 7 days is for using empiric treatment. 4 to 7 days is the area in most of the viral fevers we expect that fever will go down. If not, there is effervescence. So between 4 to 7 days, if the fever is going down, no problem. But if the fever is persisting high, you need to investigate early. But in all other conditions, if you consider that this is a viral fever, you wait for 7 days, then you investigate.
স্যার লাস্ট কোশ্চেন স্যার, কারণ ইফতারের সময় আসতেছে স্যার, রিগার্ডিং টক্সিন এজিলিটি এন্ড রেস্টলেসনেস or flushed face or any higher level of temperature does include feature of toxicity?
No. Just flushed face is not toxicity.
Dr. Ruhul,
fever more than 106 is definitely toxicity. But less than fever, if it is 105, even 105.5 does not constitute toxicity.
Sir, agility, restlessness, flushed face, এগুলা কি স্যার হয়?
Flushed face না, restlessness is a sign. Restlessness is a sign of toxicity.
Sir, last question আজকের জন্য. How to diagnose bandemia? এটা হচ্ছে by Mirza Mursalim.
How to diagnose?
Bandemia.
Bandemia. Okay, you need to, it's from peripheral blood film. It's from peripheral blood film. You need to ask the hematologist or the pathologist who is doing that to look for band form of the neutrophils. So bandemia can be diagnosed from the peripheral blood film.
স্যার আপনার অত্যন্ত দুজন শুভাকাঙ্ক্ষী আমাদের সাথে যুক্ত ছিলেন, একজন সহযোগী অধ্যাপক ডক্টর সাজাদা সেলিম, ওনার ইন্টারন্যাশনাল কনফারেন্সের জন্য মাত্র লিগনে চলে গেলেন, আপনাকে উইশ করে গেছেন। আরেকজন স্যার আমাদের সাথে যুক্ত আছে প্রফেসর দিলীপ কুমার রয়, উনি স্বনামধন্য নেফ্রোলজিস্ট বাংলাদেশের, উনি স্যার একটু আপনার সাথে অ্যাড হচ্ছেন স্যার। আনমিউট স্যার।
থ্যাংক ইউ প্রফেসর রিদওয়ান for your very elaborative and informative lecture. I think it will help all of our physicians, especially this BD. Also, thank you to the BD physicians for arranging such a nice lecture for us. So, thank you all. Thank you.
I had just studied that.
Yeah.
I will have to give a lecture.
Okay, that's good.
I had it prepared, and good. Thank you for the compliment.
That's so kind of you. That's so kind of you, যে স্যার আমরা এইভাবে একটা এরপর আমরা ওভারকাম করে আজকে লেকচার করতে পারছি স্যার। ভেরি ডিফিকাল্ট। তারপর আপনি আমাদের স্টুডেন্টদের, আর স্যার সবচেয়ে কথা হচ্ছে আপনি স্যার গত 1 মাস ধরে যে করোনা সংগ্রামটা করতেছেন, এটা পুরো বাংলাদেশের ডাক্তার সাক্ষী। আপনি আপনার চেষ্টা করেই যাইতেছেন। এখন দেখা যাক। এখন আপনি স্যার সর্বশেষ স্যার কনক্লুড মার্ক আমাদের একটা কথা হচ্ছে স্যার আমাদের আয়োজনে ছিলাম আমরা বিডি ফিজিশিয়ানস এবং টেকনোলজিক্যাল হেল্পে ছিল এসডি ইনোভেশন। আপনি স্যার এখন কনক্লুড করবেন। আপনি স্যার করোনা সম্বন্ধে যদি স্যার লাস্ট কিছু রিমার্কস দিয়ে বা আপডেট ম্যানেজমেন্ট আর কোনো আপডেট আছে কিনা, কারণ আপনি স্যার এখন আমরা অথরিটি, আপডেট কোন ম্যানেজমেন্ট বা আর কোন আপডেট গাইডলাইন আছে কিনা এটা বলে।
এটার জন্য কালকে সকাল 10টার সময় আমাদের একটা সোসাইটি মেডিসিনের এক্সিকিউটিভ কমিটির একটা আছে, প্রোগ্রাম আছে। So I refer them to listen to those. It will be a Zoom meeting and it will be available on Facebook Live. Society of Medicine, Dr. Ahmedul Kabir will
Thank
organize.
you.
The New Vista Pharma is organized. It will be
So
purely
thank you, sir.
on coronavirus, and all professors will be there. All senior professors will be there.
So thank you, sir. And with your permission, আমরা স্যার আজকের সেশন কনক্লুড করতেছি। And
Thank
আশা
you,
করি
Deyami.
ভবিষ্যতে আপনি রেগুলার আমাদের সাথে অ্যাটাচ থাকবেন।
Now,
Yes, sir.
I
Thank
must
you,
thank
sir.
I must thank all the BD physicians and all the people who attended this program at this time, just before Iftar. It was very long, and I thank you all for a very patient hearing. Thank you.
Thank you, sir.